Hello, we're going to look at integrated care, what it is, why it's important, and how we could deliver it in the Isle of Man. Conventional wisdom has it that if you're going to redesign a health and social care system, you start by stepping back from the individual, looking at the big picture and looking at costs and outcomes for large patient populations. Those of us that work in primary care, however, often feel that doing the opposite is a good way of approaching a problem, looking intensely at the healthcare of an individual and using that as a lens through which to view the entire system. So, this is Jean and Andy. Oh, and the little dog Isla. Jean is a proud Scot and a retired nurse who helps keep an eye on Andy because Andy has COPD, diabetes and has had knee and hip replacements and is very deaf as a result of driving his tank over a landmine at El Alamein. Jean looked after Andy and they lived without support and indeed were very active in the local community, supporting others. Then Jean died and Andy understandably became a bit down and at times a little confused. He'd go along to his GP but found that he could never quite cover all his problems and concerns in the 10 minutes allotted to him. And when there was a crisis, he'd end up in A&E, waiting forever. And when he was seen, he'd end up telling the story from the beginning each time to 3 or 4 different people who didn't seem to know anything about him at all, or what each other was doing. But what was certain was that they would all want a social services assessment to be sure he was safe to go home again. And that always seemed to take a day or 2 to organise. So he ended up in a hospital bed, picking up nasty bugs and worrying about the little dog at home. And when he did get home, although he could talk to his doctor and his social care workers, they didn't seem to talk to each other or the hospital, and nobody really knew what was going on. And as a result, they didn't give him the support he needed. The result of this, he knew all too clearly, was that he was likely to end up in a care home. And he didn't like that one bit. Apart from anything else, he'd lose his little dog. So Andy got to thinking about what things were like before 50 years of progress in the NHS. When Dr. Findlay and Dr. Cameron not only knew all about you, but knew all there was to know about medicine, and could sort any problem, from a major operation to somebody popping in to collect your shopping, all with a single simple telephone call. Wouldn't it be nice, he thought, if there was a single person, let's call her Leslie, who coordinated all the others and knew exactly what was going on. And they then could all have a single care plan that covered absolutely everything about him. And they could share it and update it electronically, so it was always up to date. And that meant that he and his little dog could stay at home and Leslie would make sure they were all well. And when there was a problem, he didn't have to ring for an ambulance. He'd ring Leslie for advice. And even when he did end up in hospital, it's just a matter of reviewing and updating his care plan so he could go home a lot more quickly. If he needed a seat in the shower, or home oxygen, or even an electronic tablet dispenser that bleeped to remind him when to take the tablets, Leslie could just arrange it with a single telephone call. So Andy and Isla could stay at home with their dreams and memories. And the hospital had room for people that really needed to be there and wasn't full of people that really needed to be somewhere totally different. To make this work in the Isle of Man, we need our managers and clinicians to break down those barriers between them and arrange the services round the patient in a hub. Now this is just one model of how we could deliver integrated care in the Isle of Man. The idea is simple: to deliver care from networks and teams based around existing general practices, but much augmented with other professionals, AHPs, pharmacists and so on, and adopting what the Americans term an ambulatory care approach, whereby all non-inpatient care is delivered in this fashion and coordinated by the hubs. Now that inevitably means that large numbers of hospital-based staff will also be members of these hubs, and in fact multiple hubs. All that means is they can provide a much more comprehensive service, and if they share their records, they'll all know what's going on. And for the first time, with the rollout of EMIS Web to GPs at the moment, we know we can actually make this a reality. The hubs could be self-managing on a day-to-day basis, prioritising their own caseloads. But the key principles behind them would be continuity of care and helping people to help themselves. It would be important that the hubs have access to intermediate care, something that sits between traditional general practice and inpatient hospital provision. These hubs could be commissioned to produce specific outcomes in their localities, looking at new ways of funding for primary care. However, this probably puts the cart before the horse, because we've said how we're going to deliver it without actually saying what integrated care actually is. So what functions do we include? Well, firstly, the obvious one is to keep people well and independent. Not only do we include things like the standard medical treatment services and screening, but treating minor problems which create isolation. So ensuring people have hearing aids, ensuring that minor foot problems that stop people going out are dealt with promptly, reducing social isolation, particularly in conjunction with the third sector, is really important to ensuring people stay independent and well. Increasingly, people are living longer and, unfortunately, with chronic diseases and disabilities. We know the fundamentals of treating people to keep them well in this group, and that is continuity of care and delivering case management through integrated locality-based teams, and finally involving people and their carers in planning and coordinating their own care. Other things such as telehealth and telecare can be useful, and population risk stratification can be used to identify the more vulnerable. And that's just a fancy way of saying find the people who are sickest and concentrate on them. The UK reckoned on the number of people living with 3 or more disabilities or chronic diseases will increase from 1.9 to 2.9 million between 2008 and 2018, and double within the 5 years after that. That's a huge challenge, and it means we have to completely refocus primary care away from the acute, often self-limiting disorders to dealing with these complex comorbidities. That means a major shift in GP workload and contracts. But the GPs themselves will need support, because we've seen an increasingly large gap between the generalists in primary care and increasingly specialised consultants in the hospital. We need someone skilled in managing complex comorbidities, polypharmacy and age-related problems. Now, we no longer have a hospital-based geriatric service, and possibly rightly so. But we do need something, and a consultant community geriatrician is an obvious solution, as is ensuring that we've got accessible crisis support. Not only do we need to look at intermediate care beds, whereby patients can go there rather than into hospital, but we also need to look at an integrated urgent care service between the ambulance service, A&E and meds, and this needs to work 24 hours a day. We know intermediate care beds work. We see it working in Ramsey. Ramsay Group Practice have 20% lower admissions into Nobles Hospital than similar practices from the south. It works and it keeps people out of hospital and closer to home. It goes without saying that high quality acute care is a vital part of the ingredient. But even this is changing, because increasingly we're seeing ambulatory emergency care too, where people go to the hospital to get their initial emergency diagnosis and initial treatment, and then are discharged the same day. Now that requires good medical and community services to support them when they get home. We're already seeing this model working. The recently introduced DVT pathway is a good example of it. It goes without saying that we must improve our discharge planning and post-discharge support. Both of these are essential to ensure that patients are back home quickly and safely. And coupled with that, home and community-based rehabilitation and re-enablement delivered by AHPs. Nobody should still be in an acute hospital to get their rehabilitation. Nobody wants to be in residential care. We've got to break the cycle of people being avoidably admitted to care homes straight from hospital by assessing them in their own home with health and social care support, rather than in a disorientating hospital environment. Although keeping the numbers of people in residential homes down is important, it's equally important to make sure that we improve the care for those within the residential sector. We know that care and support have been patchy for all sorts of historical reasons, but we need to stop the distressing yo-yoing of patients between hospital and residential homes when there's no need for significant, intensive medical intervention. And finally, we all want a good death. We all seem to want to die at home, yet very few of us actually manage it. And that's because we don't have the community and primary care services available to do this. We need to ensure that support, control and choice is available at the end of life. Underpinning all this, we need to change the management of the department to make this happen. No longer reactive, it must be proactive, and it must provide leadership and integration and integrate its own functions. I've mapped out all the functions needed to deliver integrated care. You'll see that it's a very large list, and equally you'll be very glad to know I'm not going to go through them one by one now, but they will be available as a download. However, reform, modernisation and refocusing of primary care is the key to delivery of all this. So why haven't we done it already? Well, in honesty, it's not that simple, and there are a huge range of challenges. First of these challenges is that we really need to get on and do this. We're already being overwhelmed by demand. Incremental, marginal change will not be sufficient. The biggest problem, however, is the impending crisis in general practice, not just in the Isle of Man, but in the British Isles as a whole. In short, we're threatening its existence, and we're running out of GPs. The ones that are left are struggling to cope. We need, as we've said already, to redesign completely primary care from scratch. However, although you might want to redesign it based on something other than generalist doctors, the reality is there are precious few alternatives available to us, particularly in the short term, So while we can look at skill mix in the medium term, the reality is we have to make working in general practice something that is attractive not only for our existing professionals but for new ones as well. The move to integrated care is a major cultural shift, and we know that cultural shifts in the NHS, not to mention in the Isle of Man, are something that is fraught with difficulty. We need a shared leadership, a patient and clinical engagement to both design and drive forward this model across all parts of the organisation, and is a key piece of work. We need something akin to the Professional Executive Committee of a PCT with real authority to make things happen. There's plenty of evidence that integrated care is cost effective, but that's not the same as cheaper. We know that simply stopping an individual going into hospital makes minimal difference to the cost at marginal rates. However, what it will do is reduce the rate of growth of admissions, which would otherwise mean more staff, which inevitably means more cost. Record sharing is inevitable and vital. We now have the technology. What we need to get is the agreement, not only of staff, but of patients. And my own view is that every time a record that is shared is viewed by a service, that the service should seek consent for the patient to do so. This will help foster patient and carer involvement. We know we have organisational structures that resemble nuclear bunkers, and we've got to get rid of them. Equally, we know that there will be some problems getting people to accept the ambulatory care model, perhaps especially from those who work in secondary care, whose work patterns are likely to change considerably. However, we can take comfort in the fact that the Royal College of Physicians' future hospital report supports this style of working, including ambulatory emergency care. There will continue to be tensions between the independent contractor status of GPs and the wider teams in managed salaried positions. However, we're going to see an increasing mix of GPs, salaried and independent, and this may help to get over the difficulty. However, underpinning all of this is that there must be a willingness by everybody in primary care and the general public to consider radical ways of extending funding to enable practices in primary care to work together in networks or federations. We know it's hard, and we know we're all busy doing the day job, but we've got to do this. If we don't, we'll pay. We'll pay not only as taxpayers, but we'll pay as individual citizens with increased morbidity, disability, and early avoidable mortality. We need to provide leadership that is shared leadership involving all parties. We need to foster and provide an environment in which innovation flourishes, and accept that at times innovation will fail, and allow it so in a way that is safe and blame-free. We need to provide empowerment for our staff and our patients, and we need to deliver this and achieve the financial flows to allow it to be delivered. But if we manage this, we will end up with a health and social care system that is designed for the island, is innovative, inclusive, informed by shared records, provides intermediate care, is interesting and stimulating for our staff to work in, is increased in quality and quantity, and is truly integrated. We can think of this as the Isle of Man's iCare programme. You'll see that we cheekily added a little Apple logo. It makes the point that Apple, rightly or wrongly, has a reputation for delivering services and products that just work straight from the box, no matter where you are. What better analogy is there to what we need to achieve for an integrated care programme? Now you may be wondering what happened to Andy and his little dog. Well, Andy got his integrated care, and he got it from the longest established provider of such, his family. He lived on for a considerable period, but eventually succumbed to his illnesses. The little dog? Well, she's enjoying her own integrated care package, sitting in our lounge, being looked after. Hopefully you have understood now why we've labelled this Back to the Future, and hopefully understand why integrated care is so important for everybody in the Isle of Man.